This event is presented to you by the Partnership to Advance Tribal Health and the IHS National Committee on Heroin, Opioids, and Pain Efforts. My name is Becky Blystone. I am a PATH team member located in Denver, Colorado. And I wanted to thank those of you who helped us put this event together, including those HOPE Committee team members, Tensi Moore and Cindy Gunderson, and many others. So before we get started, I wanted to note that we do have a chat function and a Q&A function. Please use our Q&A function to submit questions and thoughts to our speakers. We do have several folks monitoring that line. And then the chat function to interact with others, the other attendees. So thank you again for joining, and I would like to go ahead and get us started. If Francesca, you could please move to the next slide. Thank you, and I'd like to invite Dr. Brock to begin. And it looks like Dr. Brock, we have just dropped her, unfortunately, from this event. So allow me to continue just for one moment on her behalf. So we wanted to begin with
Becky.
Yes. Hi, Jane. Are you back on?
I am. I do not know why my camera.
That is okay. If you'd like to go ahead and get started, we can hear you just fine.
Okay, wonderful. Well, sorry about that. You know, the best laid plans. It just seems inevitable. Well, yeah, thank you. I'm Jane Brock, and hello, everyone. And I just wanted to say how pleased I am to be part of bringing Dr. Hawk and her knowledge and insights to this broader audience. So I'm a clinician advisor in the Partnership to Advance Tribal Health, which is a quality improvement effort funded by CMS, the Centers for Medicare and Medicaid Services. And we work very closely with the IHS's National Committee on Heroin, Opioids, and Pain Efforts, or the HOPE Committee. We try to extend their resources in mitigating and reversing the terrible toll of opioid misuse in Indian country. So as the clinician lead of PATH, I had the opportunity to attend a boot camp on addiction treatment initiation through the emergency department, which was facilitated by the HOPE Committee and Dr. Hawk, and it changed my perspective around not only what needs to be done, but what can be done to save lives from opioid use disorder. So when I was in practice, and I'm a senior physician, I know you can't see me, but I'm old. Anyway, I did a lot of screening and I gave a lot of advice, and I occasionally referred or tried to refer people to treatment, but basically the success rates of getting folks into sustained treatment was discouragingly low. And so since leaving practice and becoming more of a measures and data person, which has been the past 15 years, I've just watched the numbers go dramatically in the wrong way, like everybody, escalating opioid-related disease and death. And so in retrospect, I now realize that when I walked into the room for the boot camp, I actually had a lot of bias around this issue, essentially an attitude of those poor lost people, we need to try, but there's really not that much we can do. And then I listened to Dr. Hawk and learned about her work, and I would say my attitude is now completely different. There's a ton of new evidence and interventions that we absolutely can do, and that will make a huge difference in the lives of people struggling with substance use disorders. And so I personally am now very re-energized around this traditionally vexing treatment challenge, and hope that you all are or will be after today's session as well. So next slide. So just a bit more background, the PATH program's purpose is to improve health and health outcomes of American Indian populations by improving care quality delivered through IHS hospitals. CMS funded this contract to extend their quality improvement resources to IHS-run hospitals. And it's really a close partnership between CMS and IHS to accelerate progress around a set of aligned quality priorities for both agencies, and reducing poor outcomes related to substance use disorders is one of those priorities. So we function mostly as a supplemental workforce to support the ongoing efforts of IHS headquarters and their work groups and task forces and the area offices and facilities. We began this work in 2016, and we're seeing gains in cost savings, quality performance, and improvement infrastructure like resilient QAPI and just culture programs in IHS facilities. So for today's session, we anticipate a lot of questions, and we have a clinician, a pharmacist, and an advisor on this call to monitor chat. We may not get to all of them during this event, but we are open to further events, so keep your questions coming. And if we can't answer them during this call, we will follow up with you afterwards. So thank you. Sorry about the big glitch here right at the moment we went live. So Kristen, I'd like to hand it off to you.
Thank you. And next slide, please. So again, my name is Kristen Almaris. I'm the secretary of the IHS National Committee on Heroin, Opioids, and Pain Efforts, also known as the HOPE Committee. And we do have our 3 kind of overarching broad goals on the slide for you to review at your leisure. And in a follow along to Dr. Brock's great introduction, thank you for that. I want to encourage everyone participating to listen with fresh ears. As you can see, it really changed her perspective, and this is what it can offer for you today as well. And these strategies are really intended to assist you and support you in streamlining care for you and your patients. And as you listen, I want you to be aware of the many resources available to you, regardless of if you're well-versed in starting buprenorphine or if you're just brainstorming some ideas about starting to just expand substance use disorder treatment options at your site. There's many resources available to you, and the IHS opioids website. It's a simple URL, ihs.gov/opioids. It shares many different resources ranging from naloxone toolkit and a virtual on-demand naloxone training course to buprenorphine treatment and recovery resources, as well as technical assistance for frontline clinicians. There's also additional online resources provided near the end of today's webinar for you. So we just want you guys to leave today with a new perspective, as well as knowing that we're here to support you on your path. So without further ado, I'd like to introduce you to Dr. Kate Hawk. Next slide, please. She's an attending physician at Yale New Haven Hospital, the emergency department, and is joining us to discuss the latest research for evidence-based practices for acute care patients as it relates to substance use disorder and strategies for starting treatment in the emergency department while ensuring appropriate follow-up upon discharge. So welcome, Dr. Hawk, and thank you.
Thank you so much for having me. Can you guys hear me okay?
Yes, we can, and we can see your screen.
All right, wonderful, wonderful. All right, well, it's such a joy and honor to be here today. As was said previously, my name is Kate Hawk. I practice emergency medicine, but also primarily think of myself as a substance use researcher and have lots of experience in sort of thinking about how we can implement best practices for patients with opioid use disorder. So as we walk through sort of a broad overview and what we're going to talk about today, a lot of this is going to be done through the lens of seeing people in acute care settings and emergency settings. A lot of this is also very, very relevant to a primary care setting, or if you're seeing people inpatient in the hospital and other settings. And if you have questions as we go along, feel free to drop them in the chat. Otherwise, hopefully we'll have some time at the end to discuss. So I don't have any conflicts of interest to report. I do have some research funding, primarily federal, and then some foundation to support some of my other research work. So our objectives today, we're going to illustrate how to screen patients with substance use disorders. We're going to talk a little bit about examining the components of motivational interviewing and fundamentals of screening, brief intervention, and referral to treatment. Again, primarily with an eye towards the acute care setting. And we're going to talk a little bit about medications for treating opioid use disorder and harm reduction. And so we're not necessarily going to do all of this in a very linear fashion, but I promise we will get to all that over the course of the next 35 to 40 minutes or so. So why we are here today is, I think, essentially because of this chart right here. And so it will become as no surprise to any of you that the rates of opioid overdoses in this country have skyrocketed, starting really around 2015, and they're primarily driven by synthetic opioids, or what we call non-pharmaceutical fentanyls. And so if you see this blue line here around 2015, there's this huge increase from less than 10,000 annual deaths up to almost 60,000 deaths in 2020. And so I think that's really has changed the way that that medicine has been practiced, and needs to occur in order to really think about how we can meet patients where they are and address their needs and figure out how to, offer them evidence-based treatments and solutions to help mitigate this increase in opioid overdose. And why we're here particularly today is again, won't be news to many of you. These rates are actually quite high, particularly in American Indian, Alaska Native population. If you look at this graph here, this is older data, but this is sort of on that earlier rise between 2000 and up to 2015. You can see significant increases in opioid-associated fatalities, both for total drug overdose deaths and also opioid and heroin. So I'm just going to jump right into the DSM criteria for substance use disorders. And why I choose to start here is because I think that many clinicians, myself included, when we, sort of did your, formal healthcare training, whether it's medical school or nursing school or pharmacy school, we didn't necessarily do a great job of educating everyone around sort of what addiction is and what a use disorder is. And so, the DSM-5 criteria for substance use disorders it's really about how substance use affects your life and your ability to sort of fulfill your obligations and your roles. It's not actually, necessarily about quantity of use. It's not about whether you use or not. And so this becomes really, really relevant when we think about our goal as clinicians and trying to help people be as healthy as they can be. And as we talk about how we can try to move people from sort of higher risk use or sort of severe substance use disorders sort of down to either abstinence or less impactful use. So the three sort of buckets when we think about criteria for substance use disorders is loss of control, and that's using more of a substance than you intended, either spending more time using it or more time sort of acquiring it. If you're unable to cut down despite previous attempts to do so, if you're giving up activities, for example, hobbies, things along those lines, and if you're having craving. The other bucket we think about is sort of tolerance and withdrawal. The third bucket is consequences, and it won't be hard, to think about sort of consequences that we think of people that can be associated with substance use disorders, sort of including unfulfilled obligations at work, at school or at home, interpersonal problems with friends or family, dangerous situations such as drinking and driving, or sort of medical problems such as liver disease or complications from injection drug use. And so, as we think about sort of these three buckets, these 11 criteria are used to define whether or not someone meets criteria for a mild, moderate, or severe use disorder. And this is the same, it can be applied to alcohol, it can be applied to opioids. The one caveat is that for opioids, if you have someone who is chronically prescribed opioids for pain, for example, over time, they are going to develop tolerance and they will have withdrawal symptoms. But if they don't have any of these other symptoms, including sort of loss of control or consequences, then they would not actually meet criteria for a use disorder. If they are taking those prescribed medications exactly as prescribed on time, not sharing them, not taking them through a different manner. But other than that, 2 to 3 of any of these 11 criteria meet criteria for a moderate use disorder or mild use disorder, 4 to 5 is moderate, and 6 or more is severe. And so, this is particularly important because when we're thinking about opioid use disorder, which we'll talk a little bit more later on today, you really, so the people who benefit most from medications for the treatment of opioid use disorder are folks who have, a moderate or severe opioid use disorder. So not occasional use, but people who do have sort of a moderate or severe form of disease. So moving forward, so we know that there are huge gaps in treatment for substance use disorders. According to National Survey on Drug Use and Health survey from 2020, there were about 41 million individuals who were 12 and older who sort of met criteria for a substance use disorder, which is about 15% of the sample population. And only about 10% of those who met criteria for substance use disorders received any type of treatment. So we know that there's a huge treatment gap. We also know that there's, particularly in relation to opioid use disorder, that there is a huge treatment gap around the use of medications for the treatment of opioid use disorder, which, as I'll walk you through, a little bit. There's actually very, very good evidence to show that it does improve outcomes. And one of the reasons that, at least, in the emergency department, why, I think that it's so important to really change the way we think about our ability to meet this unmet treatment gap is, in the ED, we see many of these patients, particularly after, non-fatal opioid overdose, people come in after an injury or other things. And so, the emergency department, or really any healthcare, acute healthcare setting, is really an opportunity to help, identify people who need treatment and to provide that treatment linkage. So when we think about what our treatment goals are, this is another thing that sometimes people need to sit with a little bit, because it's different from what you might necessarily think of, or what you might necessarily have learned about sort of the treatment for addiction, particularly around alcohol use disorder. So there really is a range of treatment goals, and so as you're meeting someone for the first time, or perhaps working with them over a longer time, you really want to think about sort of what their treatment goals are and what supports you can put in place to help them sort of get to as healthy a point on this on this line, as they are able to get. And so, for a lot of people, we hope that is sort of sustained recovery with abstinence, sort of from all substances. For some people, it's really going to be, their goal is really going to be around sort of minimizing harms from ongoing use. And that is a valuable treatment to offer patients, particularly when you're meeting them, in an acute care setting, or you don't necessarily have the relationship or the trust established to help move people along. And so, that's something that, is always important just to think about when you're meeting someone, to not, if you come at somebody, particularly in the ED setting, head on with, don't use drugs, you need to stop using drugs, you're unlikely to be able to build a therapeutic relationship. And so, I kind of think of this continuum whenever I'm meeting with somebody, particularly for the first time. There are FDA-approved treatment options for medications for opioid use disorder. We're not going to get into the pharmacology of this today. There certainly, would be time to do that in another setting. There are lots of resources online, which I'll point you to at the end of this talk. So there's buprenorphine, which you may have heard of as a trade name of Suboxone. Methadone is a treatment for opioid use disorder that's a full agonist that has been around for quite some time in the US. And then there's naltrexone, which is an antagonist, and is sometimes used as the 30-day injection of Vivitrol, and it's a blocker of mu receptor. There are also certainly behavioral-oriented treatments and other types of treatment, but we certainly know that medications for opioid use disorder significantly improve outcomes. And the goal is really to help people maintain long-term treatment, whether they are on medications or off medications, but to help them sort of be as healthy as they can over the long term. As far as sort of evidence-based counseling for opioid use disorder, many patients and individuals benefit from counseling. Why we have this slide here is when we were doing some early implementation work around the emergency department, we would meet people and they would say, both in primary care practice and also from the emergency department or acute care side. And they would say, I would be happy to prescribe this medication, but I can't offer that, I can't provide the whole behavioral health, in-depth counseling and package that I would like for patients to have. So I'm just not going to do that at all. And so we've realized that, the most important part is to get people medication. It helps with craving and withdrawal symptoms, and allows people to sort of better organize their life. And that's not to say that counseling can't be beneficial on top of that, but certainly do not sort of withhold offering medications because you can't offer the Cadillac treatment program. As we say in implementation research, often sort of the benefit or the perfection is often the enemy of good in getting things done. And so there was a Cochrane review of around 35 studies with more than 4,000 patients that basically found sort of overall on a population level, those that got sort of intensive counseling in addition to the medication didn't have better outcomes. So again, this is just a reminder that, the goal is to help get people, treatment, even if it's not, if you can't offer the full sort of counseling to go with it. Often people get sort of medical management, regular medical care with their medications as they go through treatment. As far as sort of the benefit for medication, I'm going to sound a little bit like a broken record, because this is, I think, if you take one thing away from this, it really is, that medications to treat opioid use disorder, they really do work. They really are very effective. And unlike, for example, alcohol use disorder, abstinence-based therapies really just don't work very well for opioid use disorder. And the risks of a return to use for opioid use disorder, as we know, are overdose, a lower tolerance and risk for overdose. So When you're thinking about sort of what we can do to help people who have opioid use disorder to get in treatment, there are some Narcotics Anonymous or other sort of 12-step programs that focus on drug use. The thing that's really important if you're going to refer patients to one of these types of groups is to really think about, finding a group in your area that is medication friendly, because many of those groups are not supportive of medication, and we know that the retention in those groups without medicine is about less than 10%. And we know that sort of other outcomes, including morbidity, mortality, are much, much better for folks who take medications. So just to sort of tuck that in the back of your mind, particularly for people who've had experience, treating folks with alcohol use disorder, it's the philosophy is a little bit different for opioid use disorder, and the medications really are, the stakes, of a return to use are higher and from a single use, and the benefits of medications are much stronger for opioid use disorder. So this is an old study. This was done in 2003. And so this is a study that was really just looking at the benefit of using buprenorphine for, in conjunction with counseling versus a buprenorphine taper over 6 days with counseling. So if you look at sort of this line that goes across the top here, so those that were maintained in buprenorphine over the course of a year, those that were in the buprenorphine and counseling group, about 75% of them were in treatment at 1 year, which was the primary outcome of this study. And these were 40 people who used heroin and were randomized either to receive buprenorphine and counseling over a year or a buprenorphine taper and counseling. If you look down at this control group, those are the folks who only received a couple of days of buprenorphine to taper and help with symptoms of the short term, and then they were maintained in counseling. And if you look at it by about day 60, all 20 in the control group were no longer engaged in treatment. And moreover, they actually had a 25% death rate. And so, when we think about the things, when I say this, sort of the most important thing is, to help people people being engaged in treatment means that they are in touch with the healthcare system, and there are sort of opportunities to provide sort of ongoing feedback and reinforcement around, positive and negative behaviors. And so, really, the goal is really to keep people in treatment. And this is one of the studies that does really help highlight that. This is, a different way to think about it. So this is looking at mortality rates for patients with opioid use disorder. And so if you sort of take everyone in the US and say, the general population's standardized mortality ratio for, over the course of the next year is 1. People who have untreated opioid use disorder have about a 6 times higher likelihood of death over the course of that year. And so those are people who are in no treatment at all. Whereas those people that are, engaged in treatment with medication for opioid use disorder, and this is specifically buprenorphine and methadone, this actually lowers their mortality ratio to less than 2. So it doesn't get it back down to the general population, but it significantly reduces the likelihood of death. We know that there's lots and lots of data around that shows, for folks who are on medication for opioid use disorder, shows increased survival, treatment retention, ability to gain and maintain employment. There are better birth outcomes and improved quality of life of people who, again, who are engaged in treatment. It also shows a decrease fatal and non-fatal overdose, opioid and non-opioid associated mortality, decreased HIV and hepatitis C infections, and decreased sort of engagement with the criminal justice system. This is a study that was done in Massachusetts, and it was actually using sort of a linked data set where they got data from the medical examiner's office, from the emergency medical services, the EMS system, from the healthcare system, and they were really able to sort of link all this data together. And so they looked at around just over 17,000 individuals who had an emergency department visit for an opioid overdose. And they linked all their data together and basically just looked at what happened in the next year. So over the course of the next year, only 3 out of 10 of those folks actually had even 1 month of engagement with medications to treat opioid use disorder in the year following their overdose. The 1 year mortality for these folks was about 5%. So if you think about sort of otherwise these are, largely young and healthy folks who are in the emergency department, you know, a sort of 1 in 21 year mortality is quite astounding. Those that, and of those who did have exposure to methadone in the year following their overdose or buprenorphine, had, you know, a 37 to 53% decrease in their mortality. And so we know, you know, this is just another sort of data piece that highlights, you know, one, the increased mortality, and two, the benefit of getting medications to these people as soon as possible. This is another study that sort of used that data set and looked at it from a slightly different way. And they actually marched out the 1 year mortality of these individuals. They found a 5.5% mortality. And what this graph here is actually, it actually includes the number of deaths that occur in the first 30 days after this emergency department visit for overdose. And so, you know, as you see, you know, it's still, you know, it's a 1.1% 1 month mortality, you know, most significantly, you know, in the first couple of days, first week of that ED visit. And so, you know, that certainly changed the way a lot of us that practice emergency medicine think about, you know, how our responsibility and trying to get people linked to treatment as soon as possible from the emergency department. So this is a study that was actually published in our emergency department. It was led by Gail D'Onofrio and was published in JAMA in 2015. And essentially what they did was they had enrolled 329 people, emergency department patients who had moderate or severe opioid use disorder, and they randomized them to one of 3 treatment arms. So this is a treatment trial. These are people who were interested in buprenorphine, or were interested, you know, willing to be randomized to an arm that got buprenorphine. So they either got a standard referral, which is a referral to one of our local treatment options, you know, that is capable of providing buprenorphine and methadone, sort of all those treatments. They either got a brief intervention with a facilitator referral, where someone actually met with them and sat down and sort of matched out their, you know, insurance status and figured out how to get them to their follow-up appointment. Or they got a brief intervention and were initiated on buprenorphine in the emergency department, which means if they were in withdrawal in the ED, they got their first dose of buprenorphine in the ED, and then left with up to 3 days of medication and had a primary care follow-up appointment. And so the primary outcome that they were interested in was 30-day treatment engagement. And as you can see here, those that received buprenorphine in the emergency department or who left with medication sort of in hand were more than twice as likely to be engaged in treatment at 30 days. And so this has really changed the way a lot of us think about how, you know, our obligation to provide treatment initiation from the emergency department, and has really driven a lot of sort of change in our field. Another thing I just wanted to touch on is over the past couple of years, there has been a really big sort of intentionality around sort of the language that we use to talk about addiction and people who have addiction. So we're really moving towards patient-centered language. You know, we're not calling people addict anymore. You know, as far as urine toxicology screening, you know, we're not saying that they're clean or dirty. That implies, you know, the person is clean or dirty. There's a lot of stigma both within sort of the healthcare field, and, you know, a lot of, you know, patients have their own individual stigma. And so, you know, the more as healthcare providers we can provide a sort of safe space that reinforces, you know, if they're an individual with a disease that is treatable, the more likely people are to, you know, be willing to feel this is a safe space to talk about drug use, talk about treatment, and to engage in it. This is a campaign that was put together by called Words Matter. This particular slide is from, or flyers from the National Council on Behavioral Health. But there are sort of many other versions of this out there. And so, you know, on the left are sort of the terms that we're trying to avoid. And on the right, you know, is really, you know, we're talking about, you know, person-centered language. So it's a person with an opioid use disorder, or a person with an opioid addiction. You know, there's no such thing as an addicted baby. You know, we talked about this, part of why we talked about the substance use disorder criteria up front, because substance use disorders are all about behaviors, right? And impact. And, you know, certainly neonatals can have a withdrawal syndrome. You know, but they don't have addiction, so to speak. You know, we're really getting away from the phrase, you know, opioid abuse. Opioid dependence is sort of DSM-4 language, which has been replaced. You know, I already mentioned sort of the positive and negative urine drug screen. You know, we're not calling it opioid substitution or replacement therapy, because that really feeds into this idea of you're just replacing one drug with another, when In fact, what you're actually doing is, providing someone an opportunity to have a very, sort of organized day-to-day life where they have, can take a daily medication on a scheduled time. They don't have the withdrawal, they don't have the craving, and they're able to sort of better organize their life. And so, there's also some, we talked about sort of this being clean versus being sort of in, remission or abstinent, because we don't want to imply anybody's dirty because they, are either using drugs or drinking. So now we're going to move towards the sort of the screening and brief intervention bit. Before I do that, I wanted to see if there are questions, any of our monitors that we should dig into right now.
Hi, Dr. Huck. This is Catherine. Yes, there's been a lot of robust conversation actually regarding why are some reasons that self-help groups don't support medication, MAT processes. Specifically pharmacology-wise, there's one comment and one question. The comment is from Erin that Sublocade is another option as well. Mm-hmm. And a second question is Vivitrol used as medication-assisted treatment also?
Yeah, so those are actually, I'm really glad we brought those up because so Sublocade, we're not getting sort of deep dive into the pharmacology. So is a 30-day buprenorphine injection. And so there are sort of newer, traditionally buprenorphine is given sort of through a sublingual route where people put it under their tongue and then, it's absorbed rather quickly. There also is sort of newer in the past couple of years has been sort of 7 and 30-day long injections that in general people tend to do very, very, very well with. And so, we have used not the Sublocade, but one of the 7-day formulations in some of our studies that we're doing out of the emergency department. And by and large, people do very well with it. They, once they have the injection, they are, have 7 days of protection from withdrawal and craving and overdose. So the injectable formulations are very sort of exciting, and I think have the opportunity to really change the way people access treatment. As far as Vivitrol is, Vivitrol is a 30-day injection of naltrexone. It is primarily used for to help with craving and return to heavy drinking for people with alcohol use disorder, but it is also used in people who to treat for people who have opioid use disorder. The important thing about it for opioid use disorder is the data are not as strong as for methadone or buprenorphine. And part of that is because it doesn't necessarily help with craving or withdrawal symptoms. And people have to be completely abstinent of opioids for really about, they say 10 to 14 days before you can actually get Vivitrol. Otherwise, you can have what's called precipitated withdrawal. So, often people have a very, very hard time sort of, being abstinent from opioids for those first 2 days to even start the treatment. There anything else we should address now, or?
Just one item that I think you're going to be answering in a few moments as far as motivational interviewing, but on the flip side, if you could incorporate with your share how clients seek MAT without being flagged as medication seeking or drug seeking.
Yeah, so I think, and honestly, I think this is why there has been such a, honestly, almost sort of revolution of, willingness of emergency practitioners to do this. The conversation that you have with somebody fighting about whether they get Dilaudid or morphine for pain is very, very different from, I'm in withdrawal and want buprenorphine, and so, there are folks who have had, who try to, start, you start from that conversation around sort of opioid pain medications and say, I'm sorry, like we're for whatever reason, I can't offer that to you today, but I'd be more than happy to talk to you about, whether you have an opioid disorder or if you're having opioid withdrawal, more than happy to start you on treatment and refer you to somebody who can provide ongoing care. That being said, I want to be very, very, very clear. I use opioids to treat pain every day in the emergency department. I am not sort of anti-opioid. There are very clear sort of clinical indications, fractures, nephrolithiasis. So I just want to make sure that I'm not sort of anti-opioids in the emergency department, but for people who I think have an opioid use disorder, I think the conversation is just very, very different if you actually have something to offer them. Which 5 years ago, emergency clinicians would say, we have nothing to offer. I can't help you. Here's a phone number, which was always very it's demoralizing for patients, and it's demoralizing for providers, to be honest. So we like our jobs much better when we actually have the tools to help patients do better and feel better. And these medications, I mean, honestly, I think, if you have somebody who is in opioid withdrawal in the emergency department, if you give them a dose of buprenorphine, they feel better in 20 minutes and often, feel like, entirely, entirely different people is what, works fast, very effective. And I think for us, it's something that we can see over a very short time in clinical care. It reinforces, how rewarding it is to help people sort of on that step to engaging in treatment, which is the goal. All right. I do want to get into this because I want to make sure that we have plenty of time to talk about the brief intervention. And then it sounds like we'll have some time for questions at the end. Does that sound okay?
Yeah, sounds perfect.
All right, so we're going to talk a little bit about screening and brief intervention. So we're going to talk about sort of motivational interviewing. We're going to talk about brief intervention and referral to treatment, a little bit about sort of the various evidence-based counseling approaches for opioid use disorder, and then we're going to talk about harm reduction. So from a bird's eye view, when you're thinking about sort of these conversations, when you have people who walk into a clinical health setting or clinical space, they're going to interact with lots and lots of different people who have lots of different training. And so, one of the things that's important to think about is the patient experiences sort of the attitudes and stigma and sort of conversations with everyone who's in that workspace. And so, if you're thinking about sort of training, people in, either stigma reduction or, even how to talk to people who have, addiction, there are, this is something that I would really encourage you not to think narrowly. I think IHS does a really, really lovely job of very interdisciplinary care. So this is not news to many of you, but, so you want to think about, when you're thinking about who is getting training in brief intervention, it doesn't have to be a physician that's doing it. It can be done by, it can be either done by a physician, it can be done by a physician assistant in advanced practice. There are certainly nurses, who can do this and fill this role, social workers, health promotion advocates or navigators, peer navigators. Really the goal is that, this can be done by a lot of different people, and some patients respond well to different professionals and different interactions. So the most effective treatments that are, at least in the emergency department to enhance motivation to enter treatment are based on motivational interviewing. And so a lot of sort of brief intervention and screening brief intervention referral to treatment is around sort of reducing use for people who don't meet criteria for moderate or severe use disorder. What I'm going to talk about a little bit more today is really around sort of how you can use motivational interviewing to help enhance someone's motivation to engage in treatment. So, this is not a standalone thing that is going to, help someone's, it's not a standalone thing that's going to just, stop someone's, opioid use disorder or alcohol use disorder. It can be used to help reduce, risky drinking, but really I'm going to talk about how you can use it to help enhance someone's willingness to engage in treatment. So motivational interviewing is a collaborative conversation style for strengthening a person's own motivation and commitment to change. This was really born out of the work done by Miller and Rolnick, who are sort of the grandparents of this idea. So it's developed by William Miller and Stephen Rolnick in the 1980s. They're clinical tools that are conceptualized for individuals who are, we call sort of less ready to change. There's lots of data, more than 25,000 articles, in PubMed that are citing motivational interviewing, more than 200 randomized controlled trials. Really the effectiveness of MI varies widely across sort of who's doing the intervention, how the study is designed, who the patients are, how they measure the outcomes, and also sort of fidelity of delivery, affects the outcomes, how well whoever is doing the intervention, delivers it. But it can certainly be done in the emergency department by anyone to enhance willingness to consider and to enter treatment for substance use disorders. So sort of the brief definition of motivational interviewing is a collaborative conversation style for strengthening a person's own motivation and commitment to change and a spirit of really of acceptance and compassion. So it's a person-centered counseling style for addressing the common problem of ambivalence about change. And so we're going to go through this in a couple of slides, sort of the core interviewing skills. But really the idea is that we know, and I'm assuming that many of you that are on this call are clinicians, we know that if you in a clinical encounter say, don't use drugs, people are going to say, okay. If you say drugs are bad for you, this is something that people know. And so, the hook for getting people to be willing to engage in treatment and to want treatment. I mean, most people with a use disorder, they know that they have a use disorder. They know that what they're doing is affecting their life. They are interested in, maybe somewhere on this continuum of sort of being willing to consider, a behavior change. And so really the goal is to try to figure out how you can help them identify their motivation to engage in treatment and to make a behavior change. And so, we're providing us telling them what to do is not helpful for behavior change. I think we have lots and lots of evidence that doesn't really work. And so sort of the core interviewing skills are, asking open-ended questions, sort of providing affirming statements. When you hear someone say, I am concerned about my alcohol use, but, worry that that's what I do with my friends or whatever. You provide sort of reflecting statements, that can be either simple or complex. And then you want to sort of summarize, which is actually, reflecting back to the individual, what you heard them say in their words, sort of around their reasons for considering a behavior change. So the practical aspects are you want to be open-minded, you want to spend more time listening and asking than giving advice. You don't want to do a bunch of questions one after the other. You want to give people time to process and sort of think about, what their goals and motivations are. You don't want to interrupt them. You want to cooperate. It's not about us sort of forcing knowledge. It's really around sort of providing some information around what they ask for. And then obviously you want to be open and direct. So the brief negotiation interview, there's sort of 4 steps. I know everybody's like, oh my gosh, I don't have any time, in whatever my clinical practice is, whether it's the ED or primary care or inpatient setting. I mean, everybody's feeling sort of stretched in a million directions. This is something that I do in the emergency department, and this is a less than 5-minute conversation. It doesn't have to be sort of long and drawn out. This isn't, counseling in the sense that you're going to get down deep into all of the things. So step 1 is raising the subject and establishing a rapport. So obviously you want to introduce yourself. I often find that it goes a really, really long way to just, ask permission to talk about their opioid use, about their use of opioids. In general, the emergency department is a very disempowering place for people to be, particularly people who use drugs. And so, just say, is it okay if we talk about your opioid use today? And then you can also ask about sort of their physical level. Are you in withdrawal? Are you uncomfortable? Can I get you a blanket? Like really, really simple sort of rapport building stuff up front. And then, you want to sort of provide feedback. So you're asking open-ended questions about sort of how often they use drugs and sort of in what environment. You can certainly ask them if, about their drug use and, if there have been negative consequences. Do you see any relationship between your alcohol use and the car accident that landed you in the emergency department today? Do people make that connection or not? And so, obviously, if you can help them make a connection between, injuries and, ED visits or other healthcare visits, between that and their drug or alcohol use, that can be motivating for people who don't necessarily see sort of impact of their alcohol or drug use. And then you just provide feedback on the diagnosis or treatment options, from what you've told me about, how you use drugs, I'm concerned. It sounds like you probably meet criteria for an opioid use disorder. If you're willing to, here are some, there are some, I'm happy to discuss treatment options, or is there something else you'd rather focus on? So I said 4 steps, 5 to 7 minutes is evidence-based. So step 3 is sort of enhancing motivation. So if you have somebody who is like, oh, like, I'm, do want to cut back on my opioid use, and I've sort of been thinking about starting treatment. The question is, on a scale of 1 to 10, how ready are you to start this treatment right now? Or, it could be on a scale of 1 to 10, how ready are you to cut back to 2 drinks a day? Or how ready are you to carry your naloxone with you every day? It doesn't even have to be, it can be harm reduction oriented. It doesn't have to be treatment oriented. But the key is that so you provide this framework, and then you just sort of ask them, how ready are you to make this behavior change? And if they give you anything, even if they give you a 3, they say, oh, I'm a 3. The real question is, oh, that's interesting. Like you're a third of the way to being ready to make this behavior change. What makes you, being open to make that change, or what makes you want to make that change? And so often people will talk about sort of their family or their home situations or jobs or things like that. If they are a 1 on that scale, then you just need to pivot and figure out what else. I mean, that you are not going to talk them into something. They just told you, I have no interest in this thing. And so if they say sort of a 0 or 1, you can add, take a step back and sort of ask something, are there any, potential changes, behavior changes that you would be interested in making, or is there, a way that I can help you today? You want to use open-ended questions. You want to reflect or reiterate the patient's motivational statements regarding treatment. Earlier you said that you're interested in considering treatment because you want to, you think that's an important step in getting your daughter back, or whatever their reasons are. You sort of want to reflect those back to the patient, and then you can sort of negotiate and advise. And so, again, this isn't you telling them what to do, but this is you reflecting back what you have heard from them in a way that may help them reach sort of their goal, whether it's engaging in treatment, whether it's changing some specific behavior. And so you want to sort of provide a plan or next steps for either a treatment referral or how to move forward. So this is sort of the BNI cheat sheet. So step 1 is we're establishing rapport. Step 2 is providing feedback. Step 3 is enhancing motivation with the readiness ruler, and step 4 is negotiating a plan. So, we've already talked about this a little bit, but sort of am I consistent responses are, asking permission, using affirming and supporting statements. Sort of am I inconsistent is you don't want to give advice or information without permission. You don't want to confront the person. You don't want to be, directing them or give them orders or commands. It's really around sort of respecting an individual's autonomy, because we know that that's when people are much more likely to sort of engage in a therapeutic relationship and be open to considering change. Again, there are different types of, there's reams and reams of sort of books and papers and webinars about sort of how to facilitate change talk, talk about sort of preparatory talk, how important is it for you to do this? What would be some good reasons to do this? And then sort of as you're moving into step 4, you kind of think about this mobilizing statements. So, what do you think you will do? What are you willing to do? Are you, what steps do you need to take in order to engage with treatment? And so, but it's all about sort of reflecting back where you are. One of the things that's really important is that, people who have substance use disorders often have a lot of ambivalence about engaging treatment or changing their behavior. It's a very, very normal step on the road to change. Often, many people who use drugs or alcohol, there is some reason or something in their life that is sort of been an important prelude to how and why they started using drugs and alcohol. So, just be conscientious of, what people might be experiencing when you think about sort of taking, asking them to stop using alcohol completely without thinking about sort of what is another sort of coping mechanism or positive step that can be put in that place. So just be conscientious of it. We're not going to solve all the problems, but we want to think about that. Again, it's really around sort of exploration, not confrontation. People will definitely give you simultaneously sort of conflicting motivations and desires. This is all sort of part of the process of talking through sort of being ready to make that behavior change. Then this is really, really important for people who work in acute care settings or provide episodic care. This is really about the long game. So many times, if you have these conversations, this is, one conversation, is not, you're not going to necessarily see the light go off. People are like, yes, absolutely, I'm ready, sign me up here today. This is, people have been, had sort of decades of maybe less benefits, particularly in the emergency department, less beneficial interactions with the emergency department around sort of their drugs or alcohol use. You want them to know that this is a safe place for you to come, if and when you are ready to change or think about changing your drug and alcohol use. You don't want to underestimate sort of becoming a trusted ally to a patient population who has in the past felt very, very stigmatized. And, very likely someone else down the road may see the fruits sort of your labor, but just be mindful that you're not necessarily going to see it all sort of all in upfront. So screening, brief intervention, and referral to treatment, is recommended by the USPSTF. And this is really around to identify unhealthy alcohol use in primary care settings. It's really, again, sort of around based on a harm reduction model. It emphasizes reduction rather than abstinence. And this goes back to what I had mentioned before around, you're not going to be able to, a brief intervention is not going to be a solely standalone treatment for a use disorder. But it definitely can help sort of reduce unhealthy alcohol use or risky alcohol use. And so, the goal is you want to make sure that you sort of tailor your expectations for what behavior you're trying to provide assistance with to the client or to the patient. And just know that, sort of these conversations, can definitely be sort of use reduction or harm reduction based rather than abstinent based, sort of as you have them. And then obviously, if you're in a recurrent care setting, a primary care doctor, you can do multiple brief intervention sessions, and those can certainly be more effective than a single session in an episodic care setting. So the 5 A's of SBIRT are asking, advising, assessing, assisting, and arranging. So asking is sort of screening and assessment of risk level. Advising is sort of some information from the clinician around the substance use, whether they meet criteria for heavy drinking according to the NIAAA guidelines or, opioid use disorder according to the DSM-5. Talk about sort of assessing the patient's willingness to change sort of their behavior, and assisting, and then sort of arranging follow-up visits as needed. So this is just a slightly different take. It's very similar to the brief negotiated interview, but sort of a slightly different model. This is the NIDA quick screen question that can be used in a variety of sort of healthcare settings. It includes alcohol, it includes tobacco, it includes prescription drugs for non-medical reasons or illegal drugs. There's also the DAST, which if you're, if you're in an environment where you have a little bit more time to address, DAST usually takes much longer. The NIDA quick screen is like less than a minute. The DAST can actually take up to about, I think it was 8 to 10 minutes to fully complete. So it really depends on what setting you're in. The last sort of bit that I wanted to cover a little bit is sort of overall kind of what harm reduction is, what it's about. Hopefully this is not a new concept for many of you. The idea is it really is around sort of a respectful, non-judgmental public health approach to reduce individual and societal harms associated with alcohol and drug use. And it really is sort of around meeting people where they are. And it's not just about alcohol and drug use, right? I mean, this is around sort of when we talk to people who have persistent hyperglycemia with diabetes or hypertension, it's around, it can be used around sort of encouraging people to take their medications for hypertension or blood pressure. It's really around sort of building these relationships so you can help people be as healthy as they can be based on sort of what's available, where they are right now. This is information around sort of in 2018, the Surgeon General released a statement really emphasizing the importance of community naloxone distribution. And this is not just to individuals who are prescribed opioids or who use opioids illicitly, but also for friends and family. And so this is, can be either prescribed to an individual or to a family or friend who are nearby and able to respond to an opioid overdose, because we know that it is impossible to get someone into treatment who does not make it to the emergency department or any other healthcare setting. So really the first goal is really in making sure that we're able to effectively address non-fatal opioid overdoses in the community. And then this is the last little bit around implementation. I already alluded to before, perfect is the enemy of good. If you want to improve patient outcomes, from the ED or the acute care setting, it's certainly possible. There are many barriers. I'm sure I don't need to tell you what they are. You probably are sort of running through a million of them in your mind. This is actually a study that was based on an implementation study we did in sort of 4 academic urban hospitals around sort of thinking about how we build these programs to initiate buprenorphine. Sort of initial barriers that were identified were sort of lack of training and experience, concerned about outpatient linkage to care, competing needs for time and resources. Things that we found that actually were facilitators to effective program implementation were education and training, really departmental protocols that sort of clearly walk people through what to do and how to do it, and feedback on patient experiences, gaps in care. It is wonderful to hear that, that person you saw in the ED last week, that you started on buprenorphine, they made it. I just want to let you know they made it to treatment. Like, you don't get that kind of feedback in the ED, and that is building in those type of quality improvement and feedback loops can be very, very important for folks. Lots of important parts around sort of what do you think if you're thinking about sort of developing a protocol or program around how to improve care for people with opioid use disorder or other addictions. You need local champions. You want sort of buy-in, using success stories, protocols. You want to anticipate barriers and have community partners. Really sort of know your resources. In the last 30 seconds, I just want to show you some of the online resources that are available. I put some QR codes throughout because I feel like that's often easier to just snap picture with your camera, and it'll take you to the page rather than typing in. So on the left is, Yale actually has an ED initiated buprenorphine webpage that includes sort of protocols and pathways around quick start around sort of the things you need to initiate program. There's also NIDA, who's the National Institute on Drug Abuse, who's funded a lot of our implementation work. Has a website that's sort of in this teal QR code up top. They actually have sort of cases that include motivational interviewing. These cases down here in the bottom right, they're like short snippet videos around sort of engaging people after opioid overdose. I think one is an adolescent. One is sort of harm reduction oriented, but it sort of talks through how to do the brief negotiated interview and people with opioid use disorder. Other resources, the American College of Emergency Physicians, who I do a lot of work with. We have the Emergency Quality Network Opioid Initiative that has lots and lots of free webinars and content and podcasts, all that include free continuing CME credit. That's over there on the left. There's an online app through Embed around initiating that sort of walks you through how to initiate buprenorphine in the emergency department. And then there's also this the opioid use disorder and pain management website that's through IHS. That's right there. Provider clinical support system also has lots of other resources available. And then if you don't have a waiver to prescribe buprenorphine, you can just click on that link there and put in your notification. It is now no longer required to have 8 hours of SAMHSA approved training in order to get waivered to prescribe buprenorphine for 30 or less patients at a time. So I would encourage you to do that just on the off chance that you happen to be in a time where that's something that you can that you can use for a patient. So I am going to stop there. I think I went over a lot. I'm sorry.
That's okay. And why don't we actually just stay on this screen so people can jot down your email if they'd like. We only have 2 minutes left. So if you all have additional questions for Dr. Hawk, please drop them into either the chat or the Q&A section, because we can grab those and respond via email after this event. One thing I did want to capture from you all is a little bit of direction of where we could take this next. So if Francesca, you could go ahead, thank you, and deploy that poll. We just wanted to hear from all of you if there are any topics that you would like additional support on, to hear more about any of that. So we will leave that up for those of you to just read through it and select any and all that apply. The one other thing that I wanted to mention to you all is that we do offer other events, and we have one coming up next week. As you all fill in that poll, I will drop the information in for our next event is September 29, so next Thursday. And it is on workplace violence. It is a follow-up from one we did in the spring. And so I dropped the date and the title in there. And then the last piece, I guess, of operational needs for this call is I will be dropping in the survey link. Please complete this survey if you are hoping to get those continuing education credits. This is an important piece, so I am dropping that in right now. And we will leave this up so you all can take a moment to grab those links, click on them, and hopefully register for everything you need. Lastly, I just wanted to say thank you, Dr. Hawk, so much for joining us today. It was great content. Thank you for to everyone for joining us both in chat and the Q&A. Our chat monitors on the line, Jane, Kristen, and Catherine, had fingers flying the entire event. So we are very appreciative of everybody's engagement today. And Dr. Hawk, or I would like to invite anybody if you have a closing thought for our final minute or so.
I just want to add my thanks to Dr. Hawk. Yeah, thank you so much. This is you're so very motivating. Thank you for sharing your knowledge and insights. We will circle back around with our remaining questions, and yeah, please let us know what additional support in this area you all would value.
Wonderful. Thank you, Dr. Brock. And everyone, I hope you have a lovely rest of your day. Thank you for joining us today. We will send out materials and information following today's event.
Wonderful. Thank you so much for having me.
Thank you.
Thank you. Have a good day.
Thank you.